I think Gopal.
Okay. Okay, this one is my case. I'm Dr. Gopal. This is a regular epiretinal membrane surgery where after removing the vitreous hyaloid from the disc, it was taken off the retina. It's a non-myopic patient. And to my horror, I saw that there are multiple tears and retinal detachment emanating from the center, from the, right from the temporal periphery to the nasal periphery. So you had to switch gears. You had to go all over and do a vitrectomy right to the periphery, clearing all the vitreous which is anterior to the those stairs and removing all the traction on the area of the tears. Then finished with laser. I did a little more laser. Usually we do about 3 or 4 rows, but I had a heavy laser here. And the periphery, the places which were quite anterior, those areas I cryoed. And once you finished, lasering and cryoing, I put gas. And the final visual acuity of this patient after epiretinal removal was 6/12. This you can see that now the cryo probe is getting activated and cryo is coming. Had a bit of a cryo there on the anterior surface. So this is a complication which occurred basically because there was a lot more suction involved in the removal of the vitreous, the hyaloid, than the cutting. So the way to circumvent this would be to just raise it and then use the cutter to shave till the periphery rather than use the suction. May have been because of the reuse of the probe because the cutter's effectivity reduces. Thank you.
I think, again, a very nice presentation. Anand, do you want to ask any of the panelists a couple of questions and then I can...
You're muted.
You're muted.
You're muted. Anand, you're muted.
Yeah, just a question to Dr. Pramod Bende and Dr. Hemant Murthy. Any tips you would have to youngsters, beginners, to avoid this kind of a complication? This is something that can happen. So Dr. Pramod, could you take that first?
Yeah, basically what happened with a wide angle visualization system, we see more, so we do what we want to do more. Because the more peripheral retina you see, so you want to do a clean job, and sometimes when you do extensive dissection, and this is what happens generally because we are over enthusiastic. So what Gopal has rightly mentioned, that cutting is more important, and sometimes older cutter if you're using it induce more traction than a cutting, and that's what happened. Also what I feel, the way the ragged tear are sometimes what we need to understand something what is called as posterior migration of vitreous base. Because posterior border is sometimes with age is migrate posteriorly from the aura. What we know is around 2 millimeter, but not exactly 2 meter. It goes on as we age advances, is advances posteriorly and is always a ragged edge, not a uniform line. And when you induce the PVD suction, you need to induce the separate the posterior, and during that suction, when that ragged border, you can have an uneven traction along that edge, and typically those tear seems to be like that. That is because of, I would say, posterior migration. So you have to understand that concept. You have to understand that term, what it is, and you have to be careful. When you induce the PVD, you follow that edge of the vitreous separation on the retina. You see that edge-like thing, and where you feel there's an excess tug, you should stop there and just cut rather than allowing suction to proceed further.
Okay, thank you. Dr. Hemant, would you like to add something?
I think in addition to that, generally with the old cutter, because there is, when the cutting is not good, there is an incarceration of the retina in the probe. That's what, it tends to keep holding on the vitreous a lot more than it cuts. The second thing is, I think if there are any lattice, in addition to the posterior migration of the base, if there are lattice degeneration and you're forcefully inducing the PVD, so when it comes to the lattice, it starts producing the tear. I thought I saw a lattice there, so I'm curious to know whether there's some lattice there, because these are some changes which are always seen in patients. So you need to follow where you're inducing the PVD, because wherever there is dense adhesion, it's prone to produce a tear. So that's why we keep doing it very slowly and ensuring that we don't produce iatrogenic tears.
Okay, thank you. Very vital points, more points well taken. Can we have the next presentation, and then Gaurav would invite panelists to comment.
Hello. Hello. I'm Dr. Shubhendu from Deshai Hospital. It was a case of routine ERM removal surgery. After doing vitrectomy, I stained the macula with trypan blue. But just after staining with the trypan blue, I've seen there is macula seems to be boggy, and there is a track of fluid going towards the infratemporal periphery. I checked it twice. However, I have to do the ERM removal. That's why I started peeling the ERM first. And when I was peeling the ERM, my feel was just as if I am operating in a case of CSR. Macula is very boggy, very edematous, as if some kind of serous detachment is there in the macula. But just after completion of ERM removal, suddenly I noticed retinal detachment, and there was a large break in the infratemporal periphery, and retina was almost in the retrolental position. You can see. Then I injected PFCL to settle the retina. There's a large break in infratemporal periphery. I completed the dissection around the infusion cannula. Infusion cannula almost gone, just posterior to the ora serrata, and started doing fluid exchange, settled the retina nicely, and did laser around the breaks and as well as 360 periphery. And I've seen it is my infusion cannula was just beyond 4 millimeter. It was a phakic case. Maybe accidentally it has gone through the ora serrata or just posterior to the ora serrata, and maybe it is due to the anterior insertion of ora serrata that happened in this case.
Yeah, I think very nice, Dr. Borrell. I think that at this point, I'm going to have Shobit comment after this, but this is something very basic that I think a lot of us sometimes, happens in cases where the cannula may be getting twisted and it's not taped on properly. And especially in complicated cases where they've had previous surgeries, have to be very careful about, as Anand had mentioned, for the people just starting out, that sometimes it's the basic things that get all of us in trouble. Inducing a PVD, making sure the fluid is going in and out. Sometimes we worry too much about cutting and suction, but we just have to get fluid into the eye, out of the eye safely. So Shobit, any comments on how you manage and how do you prevent this from occurring?
Yeah, I would just put in my opinion, and I would like the opinion from Manish, Pramod, and you and the rest of the panel. If we notice such a thing in the beginning of the surgery, like before ERM removal, and where we are also planning an ILM peel with it, why not I would be inclined to put 1.5 to 2 ml of PFCL in the posterior pole to stabilize the whole place and avoid any peripheral central traction while I'm peeling, wandering into the periphery, and avoid that bulla from forming. What do you feel about that? Just put about 2.5 ml even PFCL and complete the peel, and then have a relook into the situation when you see a track of fluid and a very boggy macula. Peel under.
Manish, any comments?
Yeah, so I think Shobit, PFCL can be used certainly to prevent a bulla formation. But I think what I saw in the video was the bogginess partly was coming from the choroid. And maybe that would not settle down instantly unless you solve the actual problem of the fluid constantly coming. So first thing when you notice it, you could put PFCL just to keep the posterior pole stabilized. But then you go and sort out the cannula and then come back. And then if you still need PFCL, you can keep it there, or you can just take it out and do it. So that would be my way of looking at it.
Yeah, I agree with Manish. What I would have done, first thing is transfer this infusion cannula to another sclerotomy. Close this sclerotomy first, okay? And so it will prevent that bullous nature. And then you can handle subsequently very well, recheck the infusion entry, everything. And once cannula tip is properly inside, you can reconnect back to same sclerotomy. That is one. Second thing is, while making sclerotomy, sometimes you go, because you want a self-sealing sclerotomy, you sometimes go too oblique. And also while going oblique, you need to make sure your cannula, your entry should be parallel to the limbus. you slight direction towards a little bit backward, and because of you are going too oblique, you may land up inside the exit should be far posterior than actually entry site outside, and that what can lead to this type of complication also. Here, obviously, Dr. Subhendu has shown that like entry itself was a little bit posterior, but that having entry at the 3.5 millimeter, still you can land up having 4.5 millimeter, partly in a choroid, partly to the retina, and then fluid seeping in a suprachoroidal space as well as subretinal space.
And I think that one thing to realize for people who are just starting out, when a complication occurs, take a step back, figure out what's going on, and before you do your next step, think about what you're going to do, and think about if you started a case with this fluid, what would you do? So forget about anything else, but concentrate on that first. But don't get too worried about too many other things. But take a step back before you do things. That you're not in a time rush, right? You should never be in a time rush. So really take a step back and figure out, what is going on before you do something, instead of the other way around.
That's all great points. I think one thing is that in this era of MIBS, since the ports are flexible, we can always switch things around. I think that's very critical. The PFCL can stabilize the milieu inside, and then you can switch around like Dr. Pramod suggested. I think great discussion. I think we can move on to the third presentation.
Hi, everyone. This is Raman from Eye Department. So I had this case who had decentered Yamanes and oil in the eye and an inferior RD. So I removed the oil and removed the Yamanes lens. And then I found that the hyaloid was not removed during the first surgery. So I stained it and I started moving it. The RD was there. RD was there.
Meeting cholche amar.
And then we saw that the RD is happening. It was there, but suddenly we'll see it is becoming more and more bullous. And as I'm shaving the peripheral vitreous, and I realized that this bulla is increasing in size, but it has kept there in that place. So I thought, let's find out the reason why. The first thing came into my mind was whether there was an infusion cannula there. So I went there and saw, depressed with the bud, and saw around. See, the cannula is in the vitreous cavity, and that was not the reason. So I saw very nicely that around what is happening there. Is there oil there in the periphery which has gone down? So I had no idea. So then left me with no choice. I put the PFCL there, and with this PFCL, this retina is not settling down, and this is really mind-boggling the what to do next. So I had this whether to make a retinotomy and drain it, but I had always in the mind that something is there. So I thought of draining it from the outside with a non-walled cannula. I went back in the area of the detachment, and I could drain the fluid. You can see the retina going back nicely, and went back. And when I went inside, and then now I, you'll see that the retina has gone back. The PFCL has could, nicely push the retina back. Now I'll try and complete the vitrectomy. There I found the reason of this, the RD which was not going back. I found a horseshoe tear, probably which was closing down because of the vitreous there and because of the fluid there. And it was letting the fluid come inside, and then it didn't allow to go outside. So this was a thing I learned from this case, that such things can happen, but the drainage from outside really helped in this patient. Yeah.
Very nice case. Pramod, any comments on how, if you would have done anything differently? He showed a very nice technique of draining from the outside, but any comments on what you would have done, if anything differently?
Yeah, that's I think good way of. I think it's an innovative technique to drain. I would say what he has done now. Basically, the possible reason could be peripheral leftover vitreous. Initially, probably while removing IOL, must have been hooked somewhere through the vitreous. Added traction created a peripheral tear, maybe, or pre-existing, I do not know. But leftover vitreous in a periphery, what he has rightly mentioned, because PVD was not there. So this vitreous probably and acting like a wall-like things. Fluid was seeping it as the vitrectomy progresses, but not able to come out. And when he trying to put PFCL, he added PFCL, probably that also did not allow the peripheral vitreous, blocking that break, not allowing fluid to seep out. And that's why PFCL can just displace, but there is no way fluid could come out. I think this is a great way what he could do, an innovative technique, I would say. This is one of the alternative options. I think this is great in this way. Of course, another option would have been creating additional retinotomy to drain the fluid. But I think he avoided retinotomy in this situation.
Shobit, and any comments?
It's an excellent technique which he has used, and I would also not like to create a posterior retinotomy in this. It's better that the external drainage is excellent, and there's already great pressure control inside the eye, and you can titrate the external drainages.
I think these are all very good points. It's easy to make a hole in the inside because you can see what's going on. But in general, I like to avoid making more holes inside the eye. And I think that's an important principle for people starting out to understand that the retinotomies are easy to do, but they become then difficult to manage afterwards. They can.
Especially in an inferior retina. That's the last thing we want to have retinotomy.
That's right.
And moreover, Gaurav and Pramod, because of the bulla, it would be impossible to remove that anterior vitreous before, the bulla settles down. So this is the correct approach, I feel.
Yeah.
So I think that's a nice case. So Anand is going to introduce that.
Sure. Very, very nicely done, Ramandeep. Great job. We'll move on to the next presentation. Can we have the next video on Sai by Dr. Vishal Agarwal, double fracture.
Hello. Hello, this is Dr. Vishal, and I'm showing you a case of retinal detachment in which a phaco-vitrectomy was done. So during the trocar incision, these are the polyamide trocar cannulas from Bausch and Lomb, and you can see that there's a fracture between the trocar and the cannula, and it's in the sclera. So I'm trying to take it out, and it again broke, and the plastic cannula part was discharged in the vitreous cavity. So we tried to, sleeve it into the light pipe with the help of forceps and the light pipe, but we could not do it. It had rugged edges. We proceeded with the vitrectomy, cleared off the vitreous, and then floated the iatrogenic foreign body with the help of PFCL just behind the IOL. We did all the laser part and everything. We completed the vitrectomy. Because of the rugged edges, it created a lot of breaks in the periphery. And you can see the floating cannula behind the IOL, and we did a handshake technique and removed it finally. So dislodged soft tip cannulas are not very uncommon. We have seen videos of that, but these are harder than those soft tip cannulas, and they are difficult to maneuver also, and they are sharp. Thank you.
I think that's a nice case. Anand, you want to ask the panelists about their thoughts?
Yeah, Dr. Pramod, would you like to share? Yeah.
Sharing, you can just take away so that you can have a panel on the screen.
Yeah.
Stop sharing.
Okay.
Anand, I can just make a point. I think
sure, Dr.
These are the reuse of. That's why it's never good to reuse these cannulas because they are non-metallic. So they generally find it that it tends to fracture very fast. And I think it's best that because they are harder, I think it's best that we remove it like a foreign body first and then proceed with the surgery. Like how we would do a foreign body with retinal detachment. I think we proceed the same way so that we avoid iatrogenic trauma as it keeps moving around with the fluid. I think that would be a change that I would do. A very nicely done video and very good, elegantly done. Otherwise,
true. Congratulations. I mean, because you kept your cool in that situation. It's not easy to have that kind of a situation starting up first up. So the idea is to treat it as a foreign body, remove that, and then proceed like a regular case. So great job. Any comment, Dr. Pramod?
Yeah, I think fortunate now this type of polyamide things are not available now. Most of the things are metal cannulas now because those polyamide, again, what Vishal said, you try to grasp, sometimes we can get crushed and distort, and that's the reason, again, gripping is difficult, and sharp edges can cut through the retina, what he has very correctly shown. So yes, you have to be, unfortunately, we don't have a choice, but keep on reusing the instrument. And this is a typical example of, because of fracturing is because of reusing our instrument. But I think in our scenario, taking extra care before making sclerotomy, just check your trocar cannulas, check your instruments, forceps for any defect, deformity, fracture, and then use it. So you can try to avoid this as much as possible.
True, absolutely. All points well taken. Great job, Vishal.
I just wanted to make one comment.
Please do. Sure.
When people are taking out anything from the eye, whether it's this as a foreign body or anything else, for people, I know all of these guys are experienced, but for people just starting, always make your incision on the outside about 25% bigger than you think, because what happens is when you bring it up to your sclerotomy sites, you don't want it to get stuck. Absolutely. And I don't know why people worry about 2 millimeters and 3 millimeters and 4. So I always tell the fellows, put the caliper away. We're not cataract surgeons. Make it as big as you want and 25% bigger, because I don't know what the problem is, but just the last thing you want is to be stuck at the vitreous base in a phakic patient, and makes it a bigger problem. So I would say one advice to all the younger people, don't do that. Don't think like a cataract surgeon, think like a retina surgeon. Make it bigger and just take it out.
Yeah, that's why I removed the trocar while I was removing the foreign body.
I also would like to add there that ensure good base excision, particularly the area where you are going to make this larger sclerotomy to get the foreign body out.
Excellent.
And one thing for this, if you're worried about fluid flow, and here you couldn't really do this, but if you were thinking of doing it from the beginning, you can make a shelved scleral tunnel incision and then go in, and then you won't have a lot of fluid coming out, but just make it bigger. Don't think like the cataract surgeon, okay?
Okay. I hope there aren't too many cataract surgeons listening on.
Well, I mean, you know what I mean. I mean, they do very
absolutely. So I'd like to invite the next speaker. Sai, can we have the next presentation on? Yes. Dr. Joshi, Srinivas Joshi from Hubli.
Good evening, everyone. So I'll be speaking on the oil and the gas, a bubbling story. So here the patient was presented with retinal detachment. So I did a pneumatic retinopexy with SF6 gas. Post 2 days, that gas started forming the fish eggs. So much of fish eggs that it went even subretinal at many places. Now you can see there's another area where it got trapped. So ultimately I had to do a retinotomy in that area and try to remove those bubbles. And I checked in for if there are any additional breaks in this, and then lasered the breaks. And then finally, I put oil in this case. So post 3 weeks, this was the picture where the oil also started bubbling. And it was early emulsification of the oil along with the cataract. So I had to do a combined phaco-emulsification. Direct chop technique is my favorite. And then I put a foldable intraocular lens in the bag. And now you can see these multiple crystals like appearing these silicone oil bubbles. And then I did silicone oil removal. And now you can see those bubbles slowly coming up into the aspiration. Then I did a multiple fluid air exchange to remove as much as oil remnant possible. Then I went ahead, stained with the BBG and did the ILM peeling. And I looked into intraporosity because one area I suspected that there is a subfoveal PFCL, but it was not there. And then post that, after first post-op day, the air also started bubbling. And finally, after 2 weeks of the final surgery, everything went well. And the patient has around 6/12 vision and he is doing well. So the question to the panel is, whatever we injected gas, it got bubbled. We injected oil, it got bubbled. And then we injected the fluid air exchange. That is, only the air was there. That also started bubbling. So what might be the reason for the bubbles in this case? And our fellow Dr. Giriraj has named it as a bubbling story.
I think that's you've had a great outcome from a case with a lot of issues, but I would like to ask Pramod, just let's go back in time. is the whole issue of fish eggs. Pramod, how do you prevent that from occurring in pneumatic retinopexy? What is your bubble injection technique?
Yeah, basically, there are two ways you can just inject when you do pneumatic retinopexy. Once you put the needle, you ensure that needle tip is inside, withdraw needle a bit back, and now after you're ensuring that, either you have one brisk injection so that get a single bubble, or you can have a very continuous gradual injection throughout that bubble at the needle tip, and slowly it is enlarging. There are two ways you can do it. So basically the bottom line is you want to get a one single bubble. Yes, sometimes it does not work out. If you get multiple bubble, then I would suggest position the patient in such a way exactly opposite to your break, so that all this bubble coalesce, give few hours time. Never position the patient immediately where the break is. The break is the superior most part, particularly when you have multiple bubbles. So once the breaks are coalesced, then you turn the patient in a desired position the way you want, so that you do not want these bubbles to enter to the break, and particularly larger horseshoe tear, if they have and having associated traction and keeping flap open, is a likelihood that bubble can enter. Once they are inside the retina, under the retina, and then they are expanding because of your expansile gas, then you are in trouble.
I agree with you, Pramod sir. Gaurav sir, the problem here is when I injected, it was only 2 bubbles. It was 2 large bubbles of 0.6 SF6 gas which I injected. But later on, after 2 days, it formed so many fish eggs.
Yeah, that's unusual. Usually it goes the other way around, right? So that's unusual. That's something in this guy doesn't make sense.
Now, anything that was different in this patient, that is this patient having high myopia or a cephaloma? There I see some sort of small defects that are there just below the disc.
Yes, so, the small defects were there. Earlier I thought whether it could be an ODP, and something is regression back that is coming out in the retro movement, and that is forming the bubbles in this case. But there was no confirmed ODP in this case. So I also thought that there are small staphylomatous areas you can see inferior to the disc.
Some staphyloma.
Yeah.
So staphylomas can produce early emulsification of oil, but for bubbles, I don't think we can think about it.
Is he a young patient?
It's around 45-year-old, sir.
Okay, no nystagmus or anything?
No nystagmus.
Nothing.
No, yeah.
Yes.
Okay.
Nystagmus is one of them.
Because again, like saccadic movements can make a break into bubble. That's the thing. You said in between PFCL. When did you use PFCL in between something? If I overheard wrong, you not mention anything about PFCL? No PFCL use, right?
No. I used the PFCL. I tried to see what happened. The bubbles which were coming posteriorly, I had to push them to the mid-peripheral area and then did a retinotomy.
Yes.
And so that is where I used the PFCL in the first instance, in the first surgery.
Yeah, but what happened now, if you have a residual PFCL, that can induce the inflammation, and then you can have a early emulsification of the silicone oil. And also depends on which brand of silicone oil we use, because I have a few cases, we had some specific brand. If almost 3 to 4 weeks by the time patient come, have a significant amounts of emulsification in those cases, irrespective of all other factors common. So the brand of silicone oil, I think that also we need to look into it.
Sir. It is oro silicone oil, which we are using it in all the cases, and this is the only case which I found early emulsification in 3 weeks.
So I had a question for Manish and Shobit, real quick, 30 seconds each. What is your indication for pneumatic retinopexy, and in which patients do you not do it, most importantly? Shobit first and then Manish.
First of all, it's not my favorite technique any longer. And I don't do it in myopes at all. Young patients, formed vitreous, myopes, I would never touch it. I would do it only in extreme situations where I can't offer a surgery to the patient because of general indications. That's the current status of pneumatic retinopexy for the last 10 years in my practice.
Manish?
Gaurav, so I also don't practice it in its classic form, but what I do in some cases with just a classic superior bullous RD with single break, where I've taken them for a buckling kind of a procedure, I would choose that I drain externally, do a cryo or a laser based on what's there, and not put a buckle, just put gas. So I do sometimes this kind of a mixed thing, not just the classic pneumo of injecting gas and laser. I would also drain and then flatten it.
Yeah, I think pneumatic retinopexy keeps changing. And quite honestly, for me, I do use it. But for me, it's either vitrectomy or a buccal or a combination. But we do offer pneumatic retinopexy for certain selected patients. But you have to be very sure of your indirect skills. And I think that's why it's being used less and less often by the younger generation as well. Because people, when they do a primary vitrectomy, it's like a pneumatic retinopexy. So I think Pramod, one last comment and then we'll move on.
I use it very effectively is you have a buckling done, superior break, and you have a patient come back with a leakage.
Yeah.
Okay. And that works best actually. Yes. You just add a small bubble, settle down, additional laser, and done with you. You do not have to avoid.
Well, that's not primary pneumoretinopexy. That's not primary pneumoretinopexy.
Okay.